Hello, this is Fred Abbott. I posted some information about myself and a link to this video, so I won't go into more of that now. I'm here to talk to you about an idea for accelerating and simplifying the program announced by President Trump on May 17, 2025 to lower pharmaceutical prices in the United States by using what he referred to as most favored nation treatment, or equalizing prices between the United States and the lowest price pharmaceutical, the same pharmaceutical put on the market in some other developed country, which he combined with a proposal to cut out the middleman, the big pharmaceutical distribution companies that take a substantial percentage of the price that's charged to the federal and state governments and Medicare and Medicaid and various other programs, and also to pharmaceutical chains and so forth. So my proposal centers around a concept or an idea referred to as parallel importation, which in turn relies on a concept of intellectual property law called exhaustion of rights. And I'm going to provide a very brief explanation of what that's about and how it works, and then describe a bit how that might improve the situation without requiring any substantial legislative action in the United States, which is what might really slow down the type of proposal suggested by President Trump. I would start by noting that President Trump started on a soft note, saying he was simply going to request the pharmaceutical companies to lower their prices. I think it's largely a foregone conclusion that the companies will not comply in a meaningful way with a simple request to lower their prices, that this is going to require some legislative or executive action that's enforceable to be taken. But under my proposal, there isn't really a requirement of additional legislative or executive enforcement action, though you may need some minor modifications of regulations used by the FDA, but I'll get to that. So, to get started, what are we talking about when we're talking about exhaustion and parallel importation? Well, let's start here with the United States. In the United States, we have a national pharmaceutical market. We have, for the prescription drugs, this market is largely dominated by a handful of large pharmaceutical companies, often referred to as originators. I'll call it here Pharmaco. And Pharmaco will create and get approval by the FDA for putting a new drug on the market, and those new drugs will be patented in the United States, right? So they will have secured a patent. A patent is a form of intellectual property that essentially provides you with the right to exclude others from the market, to be the only one on the market for a period in the pharmaceutical arena for 25 years from the initial filing date of the patent application. So you can block, let's say we'll call another company here, we'll call it Generico. Pharmaco can block Generico from putting generic versions of patented pharmaceuticals on the market simply by suing them and getting an injunction to preventing the sale of the drug. Now, when a pharmaceutical company, when an originator first sells a drug in the United States, so whether you're going to CVS or you're getting it through some Medicaid program or from a hospital and so forth, when it first sells the drug, its patent right is exhausted. That's an intellectual property term. What do we mean by that? It means that once a person buys that from the patent owner or somebody that it controls, the patent owner loses the right, it is exhausted, to prevent that person from selling or transferring it or using it to another party, right? So You only get one chance to sell the drug under the patent. After that, it is essentially in free circulation in the United States. And we have a court, our major patent court, called the Court of Appeals for the Federal Circuit, which sits just under the Supreme Court. The Federal Circuit decided back in the early 2000s that the United States has something called a doctrine of national exhaustion. National exhaustion. And what did it mean by national exhaustion? It means that only a first sale that takes place in the United States exhausts the patent holder's right to block a third party. So, we'll call this the EU. Let's say you've got the same drug A in the EU and in the United States, and someone buys it in the EU and tries to sell it in the United States. The patent owner, prior to 2017, could block the importation of that product because the sale in Europe did not exhaust its U.S. patent right. The sale in Europe did not exhaust its U.S. patent right. In 2017, our U.S. Supreme Court changed that. It happened to be a case called Impression Products v. Lexmark, but that's a technical detail not so important for present purposes. Our Supreme Court said we don't have a doctrine of national exhaustion, we have a doctrine of international exhaustion. And what that doctrine says is the U.S. patent owner, once it places its drug on the market or its product on the market anywhere in the world, whether it's the European Union, New Zealand, Thailand, India, wherever, exhausts its patent right in the United States. So that, as a matter of patent law, intellectual property, the pharmaceutical company patent owner can no longer block the importation into the United States of a drug first put on the market in Europe or in some other developed country. Now, what does this mean as a practical matter? So now you've got a drug that's being sold for $3 or its euro currency equivalent in the European Union, and $5 or $6, let's call it $6 in the United States. There's nothing as a matter of intellectual property or patent law to prevent a third party, an importer, the U.S. federal government, a hospital supply chain, from buying the drug in Europe and exporting it to the United States, where it could be sold in competition with the very same drug being sold for $6 in the United States, right? So you would call this price arbitrage, and if it's purely a private transaction, the importer might be seeking to take a profit. So it might buy it for $3 in Europe and charge $5 instead of $6 in the United States and take the $2 at profit. That's, to a certain extent, how the parallel trade market works within Europe. But the parallel trader doesn't need to be a private party. It doesn't need to make a profit. The federal government, a state government, a hospital chain could go to Europe, buy the product, bring it to the United States, and use it and resell it as a $3 product or a $3.20 product, you don't need to be making money on that transaction. So if the federal government wants to, if the state government wants to, it can simply go to Europe or another developed country, and I'll get to the reason for that in a minute, buy the product, bring it to the United States, and create the very type of cost saving or price saving that President Trump was talking about when he was talking about MFN, most favored, the lowest price, although depending on where you bought it, it wouldn't necessarily be the lowest of those prices. It would be the same price. It would be the equal price that the drug is being sold for in another developed country. So that's the basic idea. As I mentioned, President Trump also referred to cutting out the middleman, so the big distribution chains in the United States, which do take a substantial part of the price that's charged to Medicare and indirectly through the Medicaid system and to the pharmacy chains and so forth. But if the United States or a state government employed an importing agent, they would also be cutting out the middle person in that transaction. You might pay a slight fee, you might have some minor transport costs, but in any case, you would be able to equalize the prices, which would result maybe in a 35% savings of pharmaceutical prices in the United States, maybe more. In Canada, the differential tends to be about 50%. And so now we'll turn to the next part of this equation. So why aren't importers already doing this, right? Because the Supreme Court changed the rules in 2017. The reason is the Food and Drug Administration, our FDA, has a system of regulations which it interprets to say that the drug being put on the market in Europe and the drug being put on the market in the United States, even if they're manufactured by the same company and coming out of the same pharmaceutical plant, aren't necessarily the same drug, so you have to get a separate approval at the FDA for the drug to sell it in the United States, which if it's a new drug can be quite a cumbersome process. It makes it very difficult to move the drug from one market to the other. It wasn't automatic that the markets would open up. The FDA would have to adopt a new set of rules to do this, which it is within their power to do. Existing FDA legislation does not require the FDA to make it very difficult to import the same drug from Europe as is being sold in the United States. Basically, they do that as a way of protecting the big pharmaceutical companies in the United States because, and part of their argument is, well, we have security or supply chain concerns, but the pharmaceutical market in Europe is as secure as the pharmaceutical market in the United States. If you are on vacation in Europe and you go into a pharmacy in Brussels or Paris or Frankfurt, you don't go in and say, oh, I don't want to take this European drug because it's not made as well as the drug made in the United States. You're pretty darn sure it is of the same quality, and it is. So these are basically artificial regulatory barriers that protect the prices in the United States. Now, Congress, back in the early 2000s, directed the FDA, because a lot of Americans were going to Canada, where they have lower pharmaceutical prices, buying them and bringing them back to the US. And the Congress said to the FDA, well, couldn't we implement a program to make that type of trade legally permissible? The FDA did a study, said, well, we don't think the price savings would justify the additional security concerns, so we don't recommend it. It wasn't until the early 2020s that Congress had had enough, and it directed the FDA under a new piece of legislation to go ahead and create a program to allow importation from Canada. And it required the states or Indian tribes to put together fairly elaborate plans to conduct importation under what are called SIPs. Florida had the first plan approved in January 2024. It's still not fully operational. But there's a problem with this idea of just importing from Canada. And what is that? The Canadian market is much smaller than the US market. Canada indeed is a big country geographically, but its population is much smaller than the United States. And the Canadian government is rightly concerned that if all the folks in the United States who need prescription drugs buy them from the Canadian pharmacies, that there will be a shortage of those drugs in Canada. So they're not anxious to see this program move forward. And in any case, I think pretty much without doubt, the companies, if they perceive there to be a big spike in demand coming out of Canada, they would tell the Canadian government they're restricting supplies because they want to protect their markets in the United States. So this gets to step 2 of my proposal, right? So let's assume you open up the EU market and say that anybody wanting to buy drugs for the United States, whether it's Medicare, whether it's the Veterans Administration, or it's a Medicaid program, can go to Europe and buy those products and import them into the United States. What would the pharmaceutical companies do? They'd say, well, we need to protect our prices in the United States. So the only way we can do that is to supply less in Europe. We're not going to meet that demand. And how could they create that output restraint? They could do it by contracting with any buyers in Europe, that if they resold the drugs, they would be committing a contract violation, or they could simply restrict the output of their factories to reduce the supplies. So it would be an antitrust violation, number one, if the conduct was occurring in the United States, but number two, if that conduct was taking place in Europe, we have a doctrine that says even if conduct is taking place overseas, if there is a direct, substantial, and foreseeable effect in the US market, that is a Sherman Act violation. So it wouldn't really matter if the conduct was occurring in the United States or was occurring in Europe. It would nonetheless constitute an antitrust violation because of this direct, foreseeable effect. Now, it might be that it would be a good idea for Congress to make explicitly clear as a sub-provision of the Sherman Act that this type of conduct is impermissible, because you could have arguments among the, from the companies about why they needed to undertake a certain type of action or so forth. And so to avoid prolonged litigation, to make this express violation. But you do need to do something that would prevent the companies from restricting output in order to maintain the control over the prices wherever that conduct is taking place. So there's two parts of this. First, we need the FDA to approve a broader program of allowing the importation of the products produced overseas or first sold overseas if they are the same product that is being sold in the United States. Yes, you might need to have a new barcode or label that could even say imported from Europe, or if there was some necessary information to put on the label or leaflet to include that, but you might need some additional minor labeling regulations. You would naturally want to approve who the parallel importers are, right? Because we are concerned to making sure that the people who are participating in the supply chain are people we have confidence in. But this is something that should be a matter of months for the FDA to put together, not even a matter of years. So if the administration is really serious about lowering prices, the way to do that is to allow parallel importation under FDA regulations, make it clear that it's an antitrust violation if the companies address this by restricting output, and to allow importation into the United States where you'd have prices going down, which would effectively equalize them with the foreign markets without asking Congress to adopt any type of domestic price controls, which the pharmaceutical industry has been very successful in preventing the federal government from Congress from doing. As President Trump said, they're a very powerful lobby in Washington, and they very frequently get their way. So I hope this is a clear explanation. As I said, I've posted a paper addressing this, link to this video, and you can take a look and see a few of the details. It's not a highly technical piece, but if you go where I provided information about myself, there's a number of papers posted there about this idea of parallel importation and intellectual property rights. So thank you very much.